10 questions. Cardiac action potentials and electrophysiology. Pause after each question if you need time to think. Let's go. Question 1. Which phase of the ventricular action potential is most responsible for the rapid upstroke of the QRS complex? A. Phase 0. B. Phase 1. C. Phase 2. D. Phase 4. Pause if you need to think. The answer is A. Phase 0. Here's why. Phase 0 is rapid depolarization. When the membrane potential reaches threshold, approximately -70 millivolts, fast voltage-gated sodium channels open explosively. A massive inward sodium current floods the cell. The membrane potential shoots from -90 millivolts, the resting potential, all the way up to approximately +30 millivolts. This happens in milliseconds. That vertical spike, that near instantaneous change in membrane potential, is what you see as the QRS complex on the electrocardiogram. The steepness of phase 0, how fast the upstroke is, directly determines conduction velocity. Steeper phase 0, faster conduction. This is why Purkinje fibers, which have an exceptionally steep phase 0 upstroke, conduct impulses so rapidly. And this is why anything that blunts phase 0 slows conduction and widens the QRS. Phase 0, fast sodium channels, rapid depolarization. QRS upstroke. Lock that in. Question 2. A drug that blocks fast sodium channels would most likely produce which ECG finding? A. Shortened PR interval. B. Widened QRS complex. C. Peaked T waves. D. Shortened QT interval. The answer is B. Widened QRS complex. Here's why. Ventricular depolarization, the QRS complex, depends entirely on the rapid inward sodium current during phase 0. When you block fast sodium channels, phase 0 becomes slower. Less sodium enters. The upstroke is blunted. Conduction through the ventricular myocardium slows. Slower ventricular conduction means it takes longer for the entire ventricle to depolarize, which appears as a widened QRS on the ECG. This is the mechanism of class 1 antiarrhythmics, quinidine, procainamide, flecainide, lidocaine. They all block sodium channels. They all slow conduction. They all have the potential to widen the QRS. This is also the mechanism of local anesthetic toxicity, LAST. Local anesthetics at toxic concentrations block cardiac sodium channels, slow ventricular conduction, widen the QRS, and can progress to ventricular arrhythmias and cardiac arrest. A widening QRS on the monitor in a patient who just had a regional block. Think LAST immediately. Board Pearl. Sodium channel blockade, widened QRS. Question 3. Which cardiac structure normally exhibits the fastest conduction velocity? A. A V node. B. Atrial myocardium. C. Purkinje fibers. D. Ventricular myocardium. The answer is C. Purkinje fibers. Here's why. The cardiac conduction system has a hierarchy of conduction velocities, and they exist for very specific physiologic reasons. Purkinje fibers conduct at approximately 2 to 4 meters per second, the fastest conducting tissue in the entire heart. This speed is essential. After the impulse passes through the AV node, it needs to activate the entire ventricular myocardium nearly simultaneously. If activation were slow and sequential, like a wave spreading through muscle, different parts of the ventricle would contract at different times. Inefficient, poorly coordinated contraction. Purkinje fibers solve this problem. They distribute the impulse rapidly to all parts of both ventricles, nearly simultaneously, allowing coordinated, efficient ventricular contraction. Now, the opposite end of the spectrum, the AV node, the slowest conducting tissue in the heart. Conduction velocity approximately 0.05 meters per second. This slow conduction is deliberate. It creates the PR interval delay, the time between atrial and ventricular activation, allowing the atria to finish contracting and fill the ventricles before ventricular systole begins. Remove that AV node delay, and the atrial kick is lost. Ventricular filling is compromised. Cardiac output falls. Fastest, Purkinje fibers. Slowest, AV node. Both essential. Both deliberate. Question 4. Which ionic movement is primarily responsible for phase 2 of the ventricular action potential? A. Outward sodium current. B. Inward calcium current balanced by outward potassium current. C. Massive inward sodium current. D. Inward potassium current. The answer is B. Inward calcium current balanced by outward potassium current. Here's why. Phase 2 is the plateau phase. After the explosive depolarization of phase 0 and the brief early repolarization of phase 1, the membrane potential stabilizes near 0 millivolts for a prolonged period. This plateau is maintained by two opposing currents in near-perfect balance. Inward current, calcium entering the cell through L-type calcium channels. Outward current, potassium leaving the cell through delayed rectifier channels. These opposing currents balance each other, keeping the membrane potential relatively stable, creating the characteristic flat plateau of phase 2. This plateau is physiologically critical for two reasons. First, the prolonged plateau creates an absolute refractory period. The ventricle cannot be re-excited during this time. This prevents tetanic contraction, the kind of sustained contraction that skeletal muscle can develop, which would be fatal in cardiac muscle. The heart must relax between beats. The plateau ensures this. Second, the calcium entering during phase 2 triggers calcium-induced calcium release from the sarcoplasmic reticulum, initiating myocardial contraction. Phase 2 calcium influx is the trigger for contraction. This is why calcium channel blockers, verapamil, diltiazem, amlodipine, affect both the plateau phase and myocardial contractility. They reduce calcium influx, shorten the plateau, reduce contractility. And this is why hypocalcemia prolongs the plateau, extends the QT interval, and increases arrhythmia risk. Question 5. During ventricular repolarization, which ionic current predominates? A. Inward sodium current. B. Inward calcium current. C. Outward potassium current. D. Inward chloride current. The answer is C. Outward potassium current. Here's why. Phase 3 is rapid repolarization. After the prolonged plateau of phase 2, calcium conductance decreases, potassium conductance increases dramatically. Potassium rushes out of the cell down its electrochemical gradient. Positive charges leaving the cell, membrane potential becomes more negative, the cell repolarizes rapidly. This outward potassium current drives the membrane potential back toward the resting level, approximately negative 90 millivolts. This is also what creates the T wave on the ECG, ventricular repolarization, the T wave. And this is why drugs that block potassium channels, amiodarone and sotalol, delay repolarization, prolong phase 3, prolong the QT interval, and increase risk of torsades de pointes. QT prolongation is delayed potassium-mediated repolarization. Every time you check a QT interval before giving a drug, you are assessing phase 3 of the ventricular action potential. Outward potassium current, phase 3, repolarization, T wave, QT interval, torsades risk. One concept, multiple clinical applications. Question 6. Which phase of the ventricular action potential corresponds to the resting membrane potential? A. Phase 0. B. Phase 1. C. Phase 3. D. Phase 4. The answer is D. Phase 4. Here's why. First is the resting membrane potential. In ventricular myocytes, phase 4 is stable. The membrane potential sits at approximately negative 90 millivolts, and it stays there, until the next action potential arrives. This stability is maintained primarily by potassium permeability. The resting membrane is highly permeable to potassium. Potassium leaks out slowly through inward rectifier channels, maintaining the negative resting membrane potential. Ventricular myocytes do not spontaneously depolarize during phase 4. This is a critical distinction from nodal tissue. Anodal cells, and to a lesser extent venodal cells, have an unstable phase 4. Their membrane potential slowly drifts upward toward threshold spontaneously. This spontaneous depolarization, the funny current, is what gives nodal tissue its automaticity, its ability to generate its own rhythm. Ventricular myocytes lack this. Their phase 4 is stable. They wait for an impulse to arrive from above. This distinction matters clinically because drugs like ivabradine block the funny current, specifically slowing the node firing, reducing heart rate, without affecting ventricular myocytes or contractility. Phase 4, resting membrane potential, -90 millivolts, stable in ventricles, unstable in nodal tissue. Question 7. Which cardiac tissue has the most negative resting membrane potential? A. SA node, B. AV node, C. Ventricular myocardium, D. Atrial myocardium. The answer is C. Ventricular myocardium. Here's why. The resting membrane potential reflects how much potassium permeability dominates the resting cell. More potassium permeability, more negative resting membrane potential, because potassium leaks out, leaving negative charges behind. Ventricular myocytes and Purkinje fibers have the highest resting potassium permeability, resting membrane potential approximately -90 millivolts. This extremely negative resting potential has a critical consequence. It means fast sodium channels are fully available for activation. When the cell is very negative, sodium channels are fully recovered, fully available, ready to open explosively at the next threshold stimulus. This produces the steep phase 0 upstroke, fast conduction, and efficient impulse propagation. Nodal tissue, SA and AV nodes, has a less negative resting potential, approximately -50 to 60 millivolts. At this less negative potential, fast sodium channels are partially inactivated. This is why nodal tissue does not have a fast sodium channel phase 0 upstroke. It uses slow calcium channels instead. Less negative resting potential, calcium-dependent action potential, slower conduction, spontaneous automaticity. More negative resting potential, sodium-dependent action potential, faster conduction, no spontaneous automaticity. Two completely different action potential types in the same organ, serving completely different functions. Question 8. A patient develops severe hypocalcemia during massive transfusion. Which phase of the ventricular action potential is most affected? A. Phase 0, B. Phase 1, C. Phase 2, D. Phase 4. The answer is C. Phase 2. Here's why. Phase 2, the plateau phase, is entirely dependent on calcium influx through L-type calcium channels. When calcium levels fall, hypocalcemia, less calcium enters the cell during phase 2. The inward calcium current weakens. The balance between inward calcium and outward potassium is disrupted. The plateau phase is prolonged because it takes longer for the weaker inward calcium current to be overcome by the outward potassium current. Longer plateau, longer repolarization, longer QT interval on the ECG. This is the classic ECG finding of hypocalcemia, prolonged QT interval, specifically from prolongation of the ST segment portion, the electrocardiographic representation of phase 2. And prolonged QT interval means increased risk of ventricular arrhythmias, particularly torsade de pointe. This is directly clinically relevant in massive transfusion. Stored blood is preserved with citrate, which chelates calcium. Rapid transfusion of large volumes delivers significant citrate load, rapidly binding free ionized calcium, dropping ionized calcium levels. This is why calcium is given during massive transfusion protocols, to replace the ionized calcium being chelated by citrate, and to prevent QT prolongation and hemodynamic compromise from hypocalcemia. Check your ionized calcium during massive transfusion. Replace it aggressively. Phase 2 depends on it. Question 9. During phase 0 of the SA nodal action potential, which ion is primarily responsible for depolarization? A. Sodium. B. Potassium. C. Calcium. D. Chloride. The answer is C. Calcium. Here's why. This is one of the most high-yield distinctions in cardiac electrophysiology. Ventricular myocytes, phase 0 depolarization driven by fast inward sodium current. SA and AV nodal cells, phase 0 depolarization driven by slow inward calcium current. Completely different mechanism, same end result, depolarization, but different channels, different speeds, different drugs. Why does this matter clinically? Because the drugs that affect each tissue type are different. Sodium channel blockers, class 1 antiarrhythmics, affect ventricular myocytes and Purkinje fibers dramatically. They have minimal direct effect on SA and AV nodal tissue, because nodal phase 0 does not depend on sodium channels. Calcium channel blockers, verapamil, diltiazem, directly suppress SA and AV nodal tissue. They slow phase 0 in nodal cells. They slow conduction through the AV node. They reduce heart rate. But they do not directly block ventricular phase 0, because ventricular phase 0 uses sodium channels, not calcium channels. This is why verapamil slows the ventricular rate in atrial fibrillation. It slows AV nodal conduction. Fewer impulses get through to the ventricles, without directly suppressing ventricular myocytes. SA and AV node, calcium phase 0. Ventricles, sodium phase 0. Two different channels, two different drug targets. One exam question that will find you. Question 10. Which electrolyte abnormality is classically associated with a prolonged QT interval? A. Hypercalcemia. B. Hypocalcemia. C. Hypernatremia. D. Hypermagnesemia. The answer is B. Hypocalcemia. Here's why. The QT interval on the ECG represents the total duration of ventricular depolarization and repolarization, from the beginning of the QRS to the end of the T wave. Normal QTc corrected for heart rate less than 440 milliseconds in men, less than 460 milliseconds in women. Hypocalcemia prolongs the QT interval by prolonging phase 2, the plateau phase, which depends on calcium influx through L-type calcium channels. Less calcium, weaker inward calcium current, prolonged plateau, prolonged repolarization, prolonged QT. The clinical danger. A prolonged QT interval represents a prolonged, vulnerable period during ventricular repolarization. If a premature ventricular beat occurs during this vulnerable period, R on T phenomenon, it can trigger torsades de pointes, a potentially fatal polymorphic ventricular tachycardia. In anesthesia, the QT interval matters more than most providers realize. Multiple common anesthesia drugs prolong the QT: ondansetron, droperidol, haloperidol, some antibiotics, some antifungals, succinylcholine acutely via electrolyte shifts. Before giving QT prolonging drugs, check the baseline QT. Know your patient's electrolytes. Replace calcium, magnesium, and potassium aggressively. All three affect repolarization. Hypomagnesemia also prolongs QT. Hypokalemia also prolongs QT. But hypocalcemia is the classic board answer for QT prolongation via a direct phase 2 mechanism. That is 10 questions. Cardiac action potentials and electrophysiology. Your 5 things to lock in before you go. Phase 0. Fast sodium channels. Rapid depolarization. QRS upstroke. Blocked by Class 1 antiarrhythmics. Widens QRS. Phase 2. Calcium in, potassium out. Plateau phase. Absolute refractory period. Contraction trigger. Hypocalcemia prolongs it. Prolongs QT. Phase 3. Outward potassium current. Repolarization. T-wave. Blocked by Class 3 drugs. Prolongs QT. Phase 4. Resting membrane potential. Negative 90 millivolts in ventricles. Stable. Unstable in nodal tissue. That instability is automaticity. SA and AV node phase 0. Calcium, not sodium. Calcium channel blockers target nodal tissue. Sodium channel blockers target ventricular tissue. I'm Anesthesia Buddy. Stay sharp. See you in the next one.